Hello and welcome to the Journal Club for August 2025, entitled What We Know, What We Presume, The Limits of Evidence in Modern Pain Management. Here to kick us off is the CEO of Physicians Research Center Plus, Teresa Simon.
Hi, everyone. So as Jehan said, we'll be discussing a paper. It's actually by a group from the Population Health and Medical Science Committee of the American College of Physicians. And joining us to lead the discussion today is Dr. Phil Molloy, a rheumatologist who, despite retiring, continues to be very active in caring for patients. Dr. Jehan Marcoux, who is, everyone knows, a very well-known cannabinoid researcher. And hopefully Dr. Len Kamen from Jefferson University, who is the clinical director of the Moss Rehab Outpatient Center and the member, I think he's actually the president of the PA Pain Society in Pennsylvania this year and the head of the Rothman Opioid Foundation. For next slides, for those of you new to PRC or Physicians Research Center, we have three areas of expertise. SALIS is our phase 2 through 4 clinical trial pillar. Buds Info is our analytics pillar, and we have some ongoing surveys with that. And then Cerium, which is what's being brought to you today, brings the education piece to healthcare providers, and one of those avenues is Journal Club. So if you haven't done it, I think some of you who have attended before have scanned this and filled out the questionnaire. Thank you. If you have not, please take a moment to scan it. We can also come back to this later. All right, Jehan, I think that that's it. And next slide is you.
All right, so the Cerium Journal Club's mission is to support the education of healthcare professionals with discussion of published research. We really do our best to approach each paper with consistency, fairness, and transparency. In other words, we try to convey the author's research and their conclusions for our discussion as clearly as possible. We encourage you to share this link, this Zoom link, wherever you got access to this. Share it with your colleagues. We use this Zoom link every month for the first Tuesday of the month for our journal clubs, and we'll have more information about our upcoming ones at the end of the month. So this is sort of our journal club declaration. So hear ye, hear ye. The purpose of this journal club is to educate, raise awareness, and engage in a professional exchange. We are not recommending any policy or regulatory decision and have no skin in the game or agenda with this journal club other than just education, discussing some interesting research papers. The paper we'll be discussing today is from the American College of Physicians, and it's entitled Cannabis or Cannabinoids for the Management of Chronic Non-Cancer Pain, Best Practice Advice from the American College of Physicians. And it looks like everyone on their committee is a co-author. Lots of co-authors. So before we dive in, and Phil, you will lead that discussion. I want to pause just for a little quiz, not really a quiz, a poll. Sorry, I don't mean to scare people there. It's a pass-fail. But we're going to launch this quiz just to kind of get a sense of our knowledge. We're all exposed to different amounts of data and different studies, and this review took into account a lot of different articles. So, for example, true, false. There is no evidence that nabiximols improve pain function, or quality of life. If you're unfamiliar with these terms, happy to demystify them. There is evidence that high THC products might improve pain to a small degree, but have no effect on function or disability. When used for chronic pain, high THC products are associated with nausea, dizziness, sedation, and more withdrawals due to side effects. That's withdrawals from studies, not withdrawal effects. When used for chronic pain, there is good data on long-term outcomes, including side effects, what other people might call harms. This is for the HCPs in the room. I routinely encourage any chronic pain patient who asks to try cannabis products. there are certain patients to whom I would never recommend cannabis products. Now, no pressure on answering these questions. They just determine all your future job prospects. So, and again, we're happy to discuss any of them. We seem we've got most responses in, so we'll leave it open just a little bit longer, another 30 seconds. So I think for me, for those of you who don't know, nabiximols are oral mucosal sprays. They're kind of like tinctures. Typically, the typical or stereotypical one is Sativex, which has an equal ratio of THC to CBD, but they do come in other ranges and ratios as well, especially in clinical research. All right, and we'll close it in 10 seconds. In 5, 4, 3, 2, 1. And here we go. We're going to end the poll. And we'll share the results. So, for the first question, there is no evidence that nabiximols improve pain or function or quality of life. Everyone said that's false, that there is evidence. All right, most of us are on the same page. Ooh, this one gets a little interesting. There is evidence that high THC products might improve pain to a small degree, but have no effect on function or disability. 75% said true, 25% said false. Number 3, when used for chronic pain, high THC products are associated with nausea, dizziness, sedation, more withdrawals due to side effects. 75% said true, 25% said false. Number 4, there is good data on long-term outcomes. 25% said true, 75% said false. Regarding encouraging chronic pain patients to try cannabis products, 75% said true, 25% said false. And for number 6, 100% there it is true. There are certain patients whom I'd never recommend cannabis. Now, what is interesting here is for the first 4 answers, according to the authors, and we'll dive into this a little bit, the authors said number 1, right, would be false according to their data. So we all are in agreement there. According to the authors, number 2 would be true. This is where we start to see a split in perhaps our own personal experience or data that we have seen. Number 3, according to the authors, was true. That is regarding THC products with nausea, dizziness, sedation. And number 4, false, according to the authors. There's good data on long-term health. And most of us are in agreement here that they're really, it's sort of the issue with the Schedule I status, no long-term research. And 5 and 6 don't really have a right answer. They're more discussion points. So before we move in to discussing some of the background, if there's any comments on these questions or anyone wants to, discuss them, we can pause here, but we can keep moving.
As we get into the meat of the paper, it will address questions 1 through 4 specifically when we get to their guidelines. I'd like to make a comment that this paper, by the way, is a meta-analysis followed by an integrated guidelines. It's not a single study. So this is a meta-analysis. And of course, the reason that number 4 is false is because all of the control studies are short-term. We don't have any good long-term prospective data on outcomes.
All right. So, Dr. Molloy, you want to take it away for a few slides?
I think everyone who sees patients has their palms sweat when you get chronic pain patients, whether they're on controlled substances or not. It's one of the things that gives us a lot of angst taking care of patients with chronic pain, especially. So I can tell you from interacting with clinician colleagues is that they all uniformly express challenges in dealing with chronic pain. The first bullet, acute and chronic pain, do have different pathways. That's on the next slide, I think, as well. Chronic pain, almost by definition, serves no protective function and doesn't have any survival advantage. So I don't know why we evolved to be so efficient at subjecting ourselves to chronic pain, but we have as a species. Therapeutic interventions, we know this from animal and human models, that are directed against acute pain, typically or often, or almost always, I would like to say, are different from the interventions that benefit chronic pain. So what helps acute pain doesn't seem to help chronic pain. That implies that there's a different pathogenesis or different pathways related. And of course, central factors are really important, as everyone appreciates, I think.
So I wanted to ask about the essential factors and if we had any pain docs on the webinar, people specialize in pain medicine, they could kind of comment on some of the complexity with the central sensitization. Dr. Lynn Kamen was supposed to come in and talk. This is a question for him. But if not,
We
we could.
do, yeah, we do know that your past experience with pain influences how you're going to respond to the next episode, how you grew up, what family you grew up in, socioeconomic status, how you observed your parents deal with pain influences your pain. Your state is fluid as well. Your mental state, psychosocial state at a given moment in time clearly impacts your pain experience, and it might be different 5 years from now. And this has been well documented in the literature. I don't think there's any controversy about that anymore.
So why cannabis for pain and why do we care? Well, there are no cannabinoid products approved for acute or chronic pain in the United States right now. We have Marinol and Syndros and epidemiologist, but their primary reasons for those being prescribed is not acute or chronic pain. As we've discussed on this journal club, there is a increasing public perception of some of the benefits of cannabis and cannabinoid products, particularly for pain, as perception of the risks decrease. One thing I think is well known is that patients receive a lot of times most of their information from online searches. There was a couple months where things like cannabidiol and pain were some of the most searched terms on Google over the last few years. And they also get a lot of their information from dispensaries. We know there are mechanisms to help explain how the endocannabinoid system might help with pain, such as the abundance of CB1 receptors in the central nervous system, as well as the CB2 receptors in the periphery, which play a role in inflammation associated with pain. And there's been studies targeting these receptors in animal models.
I have a comment on the third bullet, Jehan, that where patients get their information. For those of you who didn't join us, a few months ago, we had a journal club on the outcomes of patients' experience with cannabis products, whether or not it was recommended or discussed with their healthcare providers. And as this bullet emphasizes, most patients who are taking cannabis for pain don't go to their healthcare providers, but those that do, their healthcare providers are either aware of it or have recommended it, have better outcomes and less toxicity. We did a journal club on that several months ago,
Yes.
just to remind people.
Yeah, it was really surprising data. Sometimes the thing that can be a big factor in a positive outcome or more positive outcomes with cannabis products is having an open discussion with a healthcare professional about it. It's very surprising, but it was a very well, I thought, very well designed study. And it is on YouTube if you'd like to rewatch it. So let's talk a little bit about the methods. So, the purpose of these ACP meta-analyses, these reviews, is to address areas where the evidence is incomplete or uncertain. Maybe they don't have all the information on dosing or administration methods for all the different types of pain. So they call this a living systematic review. It's the Agency for Healthcare Research and Quality. We'll show some of the tables and figures from the study today. So they scored the certainty of short-term benefits and short-term harm. So you can kind of see them side by side, grouping them the best way they could. This included 26 randomized controlled studies and 12 observational studies with various formulations and administration forms. And this was not a homogeneous population that we're looking at across these RCTs. So you're talking, neuropathic pain, things like osteoarthritis, inflammatory arthritis, headache, visceral pain, some unspecified chronic pain conditions. So again, you're talking about this really broad patient population. And it looks like Len Kamen's joining us.
Most of these studies that are included, the 26 RCTs, didn't have blinded arms. So in other words, doctors want to know, all right, how does this stack up against opioids or NSAIDs or alternative treatments? Well, it's missing from the study designs. So the studies that went into this meta-analysis don't address what we want to know as clinicians. All right, no treatment for chronic pain is perfect. Is it more effective or have less harms than treatment option A, treatment option B, treatment option C? We don't have that information feeding into these guidelines.
Excellent. Welcome, Dr. Kamen. Thank you for joining.
Finally, my new office blocked my other emails. I couldn't get the Zoom link. Sorry.
No worries. Welcome to the Journal Club. You're welcome to chime in whenever you like. We're going to keep moving forward here and talk about some of the benefits. Now, Phil went through the study and pulled some quotes directly from the authors. So we're going to introduce their findings and then look at the table. So sort of like prime us to look at their data table and see if their statements match with the table. So for example, one of the things that they concluded was that there is moderate certainty, that's part of their grading scale, moderate certainty evidence that nabiximols probably improve chronic non-cancer pain severity and function or disability to a small degree. The mean daily dose across these trials was 23 milligrams of THC and 21 milligrams of CBD after titration. I think that's something like 10 sprays from the oral mucosal spray or nabiximol. There is low certainty evidence that synthetic or purified THC preparations with a high THC to CBD ratio may improve chronic non-cancer pain severity due to a small degree, but may have no effect on function or disability. The mean dose used in these RCTs was difficult to estimate. Interesting. So one of the challenges of doing these meta-analyses is the dosing maybe isn't always clear in some of these studies. They said that there is moderate certainty evidence that synthetic or purified oral CBD alone with a low THC to CBD ratio probably has no effect on pain response, pain severity, and function or disability. One of their other benefits analyses says there is low certainty evidence that combined oral purified THC and synthetic CBD with a low THC to CBD ratio in an approximate 1:2 ratio may have no effect on pain response, pain severity, and function or disability. They also said there is insufficient evidence to draw conclusions about the benefits of other cannabinoid preparations. I think the thing is insufficient evidence to draw conclusions. This includes whole plant cannabis, topical CBD, other cannabinoids. There's even a place on the table for things like the Vernix and the Varin cannabinoids like THCV and CBDV. Again, as well as comparisons with active non-cannabis treatments or between cannabis-related products.
It's interesting, the first bullet on that page is interesting because there's a lot of promotional stuff going on right now for the benefit, directing um, CBD alone as having evidence of pain. I mean, it's a promotional thing. It's all over. It's sort of like one of those rumors that's out there, and the data from this study suggests that's not true.
Like any other supplement, there's promoting materials that aren't
Right,
FDA indicated or approved or dosed or anything like that. Nothing new about people promoting
right.
for a variety of reasons.
Some of the studies included were blinded, and some were open observational studies. People knew what they were taking.
And we also have to remember that what might be out there in a free market and being marketed, we have no control over the source of that. Was it a fly-by-night online store with, you know, very erroneous labeling, or was it a
Yeah.
licensed dispensary meeting GMP like standards? Like we don't know. And maybe the packaging and messaging goes into the placebo or expectancy bias, so it could be an important part of the
Yeah.
effects. They did note some short-term harms, particularly with purified or synthetic THC that was, high THC, low CBD ratio, large increased risk for things like dizziness, nausea, sedation, and withdrawal from the particular study due to such side effects. They said there was low certainty that synthetic or purified CBD alone or with a low THC CBD ratio may not result in increased dizziness or sedation. Another thing they said is there is moderate certainty evidence that combined oral purified THC and synthetic CBD with a low THC to CBD ratio probably results in a large increase in nausea, and a low certainty evidence that this formulation may result in modest increase in dizziness and sedation. So these are some of the benefits and harms claims they made. We broke the figure up into two parts to make it a little more digestible. So we'll leave it up here with one of the claims, but feel free to look at whatever you like. But just to give us a little tour of this, Teresa, you may speak.
Okay, great. So I just have a quick question. I was just about to try to look for it in the paper, but I don't recall. Did they define their moderate certainty and did they make it, did they define that, their categories and what that meant? Or they just,
They did, but I forget the definition.
okay,
It
I'll
was
look it up while
addressed.
you guys are talking.
Yeah,
Yeah.
I'm
so
gonna
it
look,
was, I believe it was statistically defined,
okay. Yeah,
and
I'm
then
gonna
they
look it up.
color coded it here based on the confidence interval, its range. And so what we're seeing here, the top column is the product with the average daily dose. The benefits here are the first three outcomes, and then they have four short-term harms: withdrawal due to adverse events, serious adverse events, and our old pals, dizziness, nausea, and sedation. And where they think there are significance or high probability is in green for benefits and in red for short-term harm. So green is good, red, bad. So when we look at something like comparable THC CBD ratio, like a whole plant derived oral spray, you can see that there's, again, just at a high level, okay, there's three greens here, okay, and there's three reds. So, maybe there is a bit of a balance here with the benefits and estimated risks. Whereas if you look at synthetic or purified, 13 to 25 milligrams of THC, I assume this is oral, you see some improvements and more kind of concerns about risks increasing associated with it. So this might be somewhere where they say the risks outweigh the benefits, because here there is more uncertainty in these clear boxes or white boxes.
I'm not a statistician. I think Teresa is more than me, but my understanding of relative risk, RR, is that if it crosses one, it's not significant. If the relative risk crosses one, and as an example, here is what Jehan is highlighting. The relative risk is between 0.93 and 1.71. That's why it's borderline significant.
Right, so that's the
If you look at,
confidence interval, right? But it
yeah,
says that it's 18%, there's an increased risk, but when it's not
right.
significant. That's right.
Yeah. Now, if you
Yeah.
look at those red ones on the right, if you highlight one of those, look at the confidence in the relative risk is 3.57 here, and it's 2.42 to 5.6. That doesn't cross one, so this is a higher certainty, and it doesn't cross one. So this is
Yeah,
a
no, this one's
moderate
statistically
to
significant for sure.
significant magnitude of benefit, and it's far away from one, so that's significant. So relative risk crossing one detracts from the power. And the further it is away from one, the more powerful it is. That's a real effect.
Yeah.
In case anybody wants to go through these tables. Jehan put the table, figure one rather, in two parts. This is part one.
Yeah. And we're happy to come back to this figure if there are questions, comments, or anything like that. Well, we can take a gander at the other half of this figure. And here we have the synthetic or purified CBD alone with average dose of 30 to 600 milligrams. So a wee bit of a range there.
Yeah,
And then you have
Can I just
combined.
make a comment? I just want to make a comment
yeah.
about the confidence intervals. Okay, because I'm looking at it, like, for example, sedation has a relative risk of 5. It's the furthest one, but the confidence interval is really wide. And the confidence intervals are also,
Are you talking about part one?
talking about figure one. Yes. All
So,
the way over. Nope, the other one that you had.
oh,
Oh, is that it? It should be 5. Nope, the other slide. Sorry, part one. Yeah, 5 is sedation 5 there.
Yes,
And it's,
sedation.
yeah, and so the confidence interval also, what affects that is the number of studies. Usually you do forest plots when you do meta-analyses, right? When systematic reviews, you do, and you show the sample size of the papers because that also has a big factor and contributes to the width of those confidence intervals. So the wider they are, the more unstable they are. So when they're really pretty tight, there's more confidence that the truth falls within that confidence interval. When they're really wide, sometimes you get really wide confidence intervals.
So
So
2 to
I just
12,
wanted
that's
to
pretty
add to
wide.
that. Yeah, I just wanted
That,
to add to that, Phil.
okay,
And it's
gotcha.
also sample size, like if
Yeah.
they did number of studies or number of people, if they weighted them. So all of that goes into it.
all right.
I'm being motivated to go back and read this paper again. Pain is such a huge thing for cannabis. Yeah,
Yeah, for sure.
I want to look at it again. Okay, go ahead, Jehan.
Yeah, and so similarly, we have the combined purified or synthetic CBD, and they're looking again at wide ratios of combinations of THC and CBD. They also have low THC to CBD ratio products and a category for other cannabinoids, but just say there is, a lot of evidence lacking here. So seems like a good opportunity for research would be surveys and observational work to get us started on looking at these other rarer, minor, not so common cannabinoids. I'm surprised that cannabigerol didn't make the risk, but people are more interested in that for mood and anxiety.
Dan, when they say synthetic CBD, that means they're actually manufacturing a CBD analog.
Correct. So it could be like epidiolex that's purified, or it could be something that was synthesized as well.
I'm not familiar with synthesized CBD.
It's a good question.
Yeah.
I'm sure it's available for research purposes. If you want a really expensive clinical study, I guess.
Enough, but it's all grown from plant material as I understood it. And part one of that as well, it mentions synthetically derived THC. Are they using delta 8 THC or something different?
It seems like it was either Delta 9 or like Marinol. So that'd be minus minus trans isomer of Delta 9. So I believe it would all be Delta 9. Yeah, that is one of my pet peeves as time goes on, is everyone says THC. And I'm like, okay, which of the hundreds of possible compounds are you referring to when you say class? You know, it's like referring to human beings as being in kingdom, the mammals. It's like there was a mammal spotted walking into 7-Eleven, and you're like, okay, well, that's a broad category. It's just like saying THC. You have several isomers of delta 9, delta 8, delta 6, you have HHCs, you have a whole range of things that would qualify as a tetrahydrocannabinol. So definitely, I think we'll see the nomenclature get a bit more specific in the future.
They do have a notation on the meaning of pain response versus pain severity. I mean, they're using numerical or VAS scale to say yes or no, I had a pain response, and then what was the severity of that pain on a Likert scale. I'm not sure how they differentiate that from the 29 different articles that they reviewed. And were there consistencies in that assessment tool for pain? And of those 29 different articles that were systemic reviews of pain.
Well, that's exactly right. And that was going to be my end comment, Dr. Kamen, is that from the patient-reported outcomes, they don't talk about what measures were actually used. To your point, like what scale was the pain? They don't discuss that, which makes you really can't interpret anything then, because from an outcome standpoint, with whether or not it actually worked, is if you don't have the same measure or tool that's administered across the studies. So they could have used the Juan Baker, right? If they used the classic Juan Baker, then at least they all use something, and it's the same thing, right?
Right.
So,
But if they didn't use all the same thing, and I doubt that they did because there is no standard, it diminishes the weight of this entire article.
yeah. And to go back to the synthetic versus natural CBD, so I just did a quick search. So because Firmenich, I don't know if you know Firmenich, they make a lot of like fragrances and essential oils and mostly food types of things. And they are producing a synthetic CBD, mostly for research, to Jahan's point, mostly for studies. And that doesn't have then other cannabinoids in it. So it's a more purified version, so they can do clinical research with it.
All right. Excellent points of discussion. And I like where we're going already with, well, what is this paper worth if they're combining all these methods? We don't know the methods. I do like the idea of having an N number for the studies in this table. That might, I think, be helpful and allow us to understand the gravitas of their interpretation. But they did give us some hints about their interpretation, and it comes in the form of their best practice advice, which I think, again, just as someone who's been a patient and visited a clinician, I think these sound pretty good, but I'll let the HCPs tell me what they think. But they suggested, based on their review, that you should counsel patients about the benefits and harms of cannabis or cannabinoids when patients are considering whether to start or to continue to use such products to manage their chronic non-cancer pain. Similarly, they talk about counseling vulnerable subgroups, that the harms of use for chronic non-cancer pain are likely to outweigh the benefits in young adults, adolescents, folks with current or past substance use disorders, patients with serious mental illness, or frail patients, or those at risk of falling. And lastly, they said that they advise against starting or continuing to use these products to manage chronic non-cancer pain in patients who are pregnant or breastfeeding or actively trying to conceive. which if you have been attending these, we spent 3 months or 3 journal clubs exploring the topic of cannabis use in pregnancy from different researchers, different original articles. Oh, and also they advise against the use of inhaled cannabis to manage chronic non-cancer pain. I would guess this might be a little bit of a contention because inhaled, any form of inhalation, obviously no one should be smoking anything, but even vaporizers seem to be off the table with this group.
But again, were these addressed in their meta-analysis, or they're just saying, this is a good idea, guys. Here's some good ideas. They're throwing them out. I don't know how this was addressed specifically in the data gathering portion of that article.
That's a great comment, Dr. Kamen, and definitely it reminds me of something a mentor used to say to me, which was, don't overreach, just take what's in front of you. And they have all this stuff in front of them, yet they're reaching way over here. Hey, we didn't really look at administration forms, but we're going to like reach over here and say this. It almost feels like it's obligatory.
I can't argue with any of them. They're all right, but was this addressed in the article? And the answer is no.
So it would have been fair to say we have no data on inhaled cannabis for chronic pain. It would be fairer to say that.
They did touch on Tashkin's study and mentioned cancer risk and risk of COPD, maybe bronchitis. They kind of
Right.
passed over that. But you're right, it wasn't part of their sort of objective with the meta-analysis. They're throwing it in there.
The methods are very short in this paper, which typically for a study like this, there's a little bit more meat around the methods as to how they selected them, what they did, how they excluded certain things, but you don't get any of that. You don't even get the figure. I don't think there's not even a figure that has sort of that, how they went about it.
Oh, that is a very important first figure to usually have, that flow chart of what they looked at it, how did they find it, what was the criteria for inclusion, exclusion. Maybe they found 100 studies and only included about 30. Like we really don't know. Did they just include the first 26 they found? Like we don't know. So that there led them to this conclusion. For many patients, the current evidence suggests that the harms of use to manage chronic non-cancer pain outweigh the small potential benefit. Just drop this to the group. I don't know if you have any thoughts on this, Dr. Kamen. It seems like you were hinting at that while they did, put together a nice looking paper, they did some work here, that it's hard to draw any substantive conclusion from the work because of their methods, perhaps.
It's frustrating to be a clinical doctor. Len, you would agree. We're going to take care of these people. And all right, so if this is disappointing, if the benefit harm ratio of cannabis interventions for chronic pain are disappointing, what are the alternatives? How can we help these patients? And opioids not the answer. And what else do we have? And most of these studies don't have comparative arms. I would like to know if this is better or worse than opioids. I would like to know, but it's not answered by any of these studies.
I think they're making a premise that taking a substance of this sort should, fix the problem that they're trying to fix here, pain, and it just doesn't work that way.
Right.
And the premise is that they're holding it up to some golden standard that doesn't really exist, because we know opiates aren't the answer either. And I just pointed out in my little comments I made previewing this this article that pain is a cognitive and affective experience when it becomes chronic, and we know that cannabis affects the cognitive and affective aspects of human thought and mind, not necessarily the physical aspects of it, which is more what an opiate does. Cannabis isn't an opiate. So they're holding this up to a standard that doesn't seem to be held upable. It will never be.
Hmm. Applying an unfair standard to the cannabis plant. uh, but great points, Len. But I think that is true. This could have benefited from a little more context or perhaps a comparator. So in the interest of time, I want to get to a couple of other things we have. So again, they do caution against adolescent use. It's also featured in a recent book by Hilary Mursak that both Phil and I contributed to. They talk about, caution against use in patients with serious mental illness, as well as cannabis use during pregnancy. So one of the things they talked about was patient conversations. So if you have someone who comes in and says, "Doc, I've heard cannabis products might help. Do you suggest I give it a try?" We know that just turning a blind eye, as it were, is not necessarily helpful, and that people benefit from having those discussions. But what I really wanted to jump to was this figure was really interesting. Discussion points with patients who are considering cannabis or cannabinoids to manage their chronic pain. So they have some, interesting talking points about it's difficult to apply what we know because of the products in dispensaries is, higher than what is used in studies. So they're talking about like potency, it's best to use the least amount of THC necessary to achieve a beneficial effect. Sort of ignores the economic argument that, if they get a lot of THC, the cost per milligram is less for them to use it. But they have some interesting ones here. I thought this one was really great about a patient should keep a record of their daily cannabis or cannabinoid use, dosing, timing, and the effects, and things like that. So I think and there are tools available specifically for cannabis products that people have developed, apps and things like that.
Can't argue with any of those points.
I'm happy they put this figure out there. I think it makes me think about my own practice.
Yeah, I thought this was a little bit of a jewel in there, and that they actually included some references for at least one of the discussion points.
Yeah.
I thought this was a pretty good playbook to have a conversation. So we do have a few questions and some strengths and weaknesses, but I'm gonna read through them just in the interest of time. And if anything pops up, just feel free to start talking over me. But some of the questions we thought about were, what are your biggest challenges in knowing what to believe about the potential role of cannabis in chronic pain? How might you respond to patient queries? Other questions, what steps should be taken to educate healthcare providers and patients? Are there ethical considerations for recommending cannabis products for chronic pain? Are there future studies you'd like to see? And, in your experience, is your experience consistent with the paper's conclusion? Do you have any other thoughts or comments? I think the last thing we'll talk about is strengths and weaknesses of the paper. But I just wanted to pause here to give everyone who hasn't spoken or who has spoken another chance to talk, or we can just stare at each other for a moment of silence.
Well, actually, Jahan, I would like to go back to the tips about how to engage your patient. And I'd like to ask the physicians that are on the call, right? So Mark and Dr. Dan, and if Anne sees patients, like, is this how you typically, do you use any of these tools, or is there something new that you've actually maybe learned and might say, oh, you know what, I might actually try to use this approach or something? Like, I just want to know if this is like bringing this to your attention. Is this helpful? Does it help sort of like focus the conversation with your patients?
It's humbling to have to admit that we have insufficient data to give them good answers. We don't have the information we need to give advice. I find myself personally falling back on anecdotes and saying, well, I've had patients similar to you who have tried this kind of a product and some have benefited from it. So I just give anecdotes sometimes because basically that's what the literature looks like now anyhow.
Well,
Until
what
it's not,
about,
Yeah, Dan was going to say something.
yeah.
I'm sorry. Sorry, Phil. Um, what about the 2018 report from the National Academy of Science, Engineering, and Medicine? Um, you know, that was a Herculean task that I think gave us some reliable information about chronic pain. I'm trying to remember exactly the way they put it. They did indicate that there was good evidence for things like chemotherapy-induced nausea, and I'm
I
pretty
think they
sure they
said there
included
was,
pain in there.
yeah, I think they said there was moderate evidence for chronic pain or some forms of pain in their conclusion. I'd have to look it up. I think they put out a cheat sheet for that NASM report. But that is a great point, Dan. That was a monumental review they did of like 10,000 articles in total or something like that.
If I recall, I think the most potent evidence they had was in spasticity patients. And it's an anti-spastic effect, which I think has a lot of validity and is much cleaner to measure in a sense than pain is, by the way.
Absolutely. Absolutely.
Dan, as you read the emerging literature since 2018, would you agree that there's been more of a focus on non-pharmacologic interventions? Just trying to get the focus off of pharmacologic interventions in terms of pain and quality of life or functional status.
Yeah, that's clearly important in these patients because they have, you know, the phrase sometimes we use is bundling
Right,
of the pain lifestyle, and
right.
you know the fact that even if you treat, my experience, personal experience, I'm a neurologist. My personal experience is when someone with chronic pain comes in and you help them, the pain actually moves to a different part of the body, and because they need the pain because it's part of their persona. Uh, or relationships. And so I agree, it's a complicated bundling that you have to unpack, and
Right.
non-pharmacologic interventions are very important for these patients. Absolutely.
I think
Do
one of
more
the
yoga, I mean, just do more yoga. That's what Dr. Kamen always tells me, just do more yoga. You doing your yoga every day?
I think the most important part how why people use marijuana for pain, medical or otherwise, is that it's an empowering thing. That it's something they control, albeit if they get a general certification or a license in several states, you don't even need that. Uh, but it's the empowerment that this gives them over everything else, which as they imbibe it has to be usually prescribed and monitored and overly regulated by other forces. So it's the self-empowerment that people are seeking. And as again, I've said before in my preview of this was, it's people will do a lot of things for suffering despite the side effects, which are to them relatively minor compared to the empowerment they get and the diversion that they get from using this type of product that affects their again, cognitive and affective aspects of pain, not measured by these studies, really.
So there's something
And
about,
if you can grow your own, if you
yeah,
can grow your own, that adds to that empowerment.
there's
Yeah,
something
an
passive
important
about,
aspect for sure.
there's something passive about give me a medicine, give me a pharmacologic, give me something I can take as opposed to exercise, cognitive behavioral therapy, yoga, physical activity stuff.
That's a great point because the discussion points here don't really ask about some of those other factors, like
Right,
their lifestyle factors, and maybe that's
right.
implied. But I think that is a interesting point. Are you planning on using this medicine to be more active? Are you planning on using this to be more active, or so you can sleep? Like what aspect of pain are you trying to navigate? Would be a good discussion point to have because you might want to advise against, well, if you're gonna don't take this and drive to the yoga studio, you know, to take a hire a car or something like that. um,
Yeah, I
But
mean,
that's a really good point. It's very, what aspect of the pain are they trying to control, right?
and
And
how active, how much effort is the patient willing to put in? I mean, can you
right.
just give me something for my pain, doctor? I don't have the time to go to physical therapy. I don't have the time to exercise. Just give me something.
The magic pill, right? They want the magic pill.
Well, you guys are talking about nuance, and there was no nuance in this article. In fact, the whole purpose of this article, I believe, is to provide a very conservative approach to a wide range of internists that know so little about cannabis therapy that they need guidelines. And in general, these guideline types of publications are notoriously um, limited in terms of nuance. And what makes it worse, I think, is that they're used in medical legal situations as sort of a guideline for standard of care. And as such, they have to be extremely narrow in their recommendations and lean way towards the conservative end of the spectrum.
I That's a great thing, and since we're headed there, I want to jump to our strengths and weaknesses because I think Dan, you served that up really well in terms of what they are perhaps able to say, but what their goal was or mission was with how they wanted to approach this. Because maybe they could have refined it a little bit more, like with their various preparations. I don't think they really did a good job of separating out the diversity of these products and delivery forms. It really seemed to be just oral products. Um, One of the things I think Len and Phil both commented on before we hopped on this journal club was that the no universal comparator for opioid exposure. What was the average MME dose, the morphine milligram equivalents of opioids used in these patient populations? What sort of opioid exposure did they have? We can, really wasn't taken into account in the meta-analysis. Another issue I have with a lot of the observational studies is the time traveling cannabis plant issue. And you see this a lot in observational studies. A lot of retrospective studies have this, where they ask about cannabis use from the last week or last month for something that's been going on for 5 years. Sometimes it's like, then they try to make an association, and I understand there's limitations with recall for what people remember and how accurately, but it just seems odd to me that we look at such this most recent window of perhaps cannabis use or a short-term window of cannabis use and not really saying, well, what has your use been up to this point before and after the chronic pain issue? We really, I think, don't know much about that. And it's even more apparent when you're looking at harms, because sometimes people will be like, oh, you had a heart attack 5 years ago and you've been using cannabis the last month, and then you're going to associate cannabis use with heart issues. And it's like, well, that's maybe they've been using cannabis the same way for the last few years, but we don't know. So that's one of the issues I think with some of these observational studies that could be skewing these results or creating sort of gray areas is this temporal issue of cannabis use in observational studies and things like that. Well, if you like this study, there's plenty more out there. I suggest checking out clinicaltrials.gov. There's lots of studies looking at different types of pain and things like fibromyalgia, opioid tapering. There's also been some other reviews about medical cannabis for chronic pain management, and this one actually dove into a little bit of the medical legal issues. But since we don't have a lawyer on our volunteer team here yet, but maybe next time, maybe in the future, we'll bring one on. But I think all the doctors kind of start to sound like lawyers in the cannabis space once they've been here a while.
Yeah,
Hope not.
so thanks, Jehan, for highlighting the fact that you, Phil, and Dr. Kamen are always spending extra time on your life on this to bring Journal Club to those that attend, and I know we do make it public for people to share. So share the recording if you like, but thank you for you guys volunteering, like Jehan said.
And so the last thing, just to round it out, thank you, Teresa, is that our next one is Tuesday, September 2nd, so first Tuesday of every month. We're going to be looking at some heart research from that recent Stork article. Tuesday, October 7th, is going to be a fantastic one. It was an accidental exposure, a mass intoxication event that made its way to the CDC. So we're going to dive into those two and break them down and discuss them. And again, please email us, contact us, let us know what you think of this time. Does it work well for you? Would another time work better? We've tried night, we've tried afternoon. Would 2-3 hours later work better? You guys want to do it at 6 in the morning? Feel free to drop us a line. We're open to moving this around to accommodate as many people as possible,
Very
as
well.
often as possible.
Thanks, guys.
All right, thank you.
Thank you.
All right.
I